Hello, our dear students. Previously, we finished cycle of lectures about gastrointestinal disorders, and last lecture was additional and about ACG interpretation. And now we continue our cycle of lectures according to our thematic plan, and topic of our today's lecture it is signs and symptoms of endocrine organ diseases and metabolic disorders. About this system we will have just one lecture, it is today. According to thematic plan, it have to be about diabetes mellitus, but I made it a little bit wider and I included more information, and I want to make an accent on thyroid gland and pancreas. Plan of our today's lecture: to give a definition of endocrine system, to describe spectrum of endocrine diseases and metabolic disorders. And I want to stop on two main disorders in this system. First, it is disorders of thyroid gland. Yes, in this part we remind how do thyroid gland works, history taking, patient's examination, clinical laboratory and instrumental, and the most often symptoms and syndromes. And another thing that I won't stop on, it is endocrine pancreas. Yes, it is. It will be a reminder too how do pancreas works. History taking, patient's examination in endocrine pancreas disorders, including clinical, laboratory, and instrumental too, and symptoms and syndromes of disorder of this organ. Okay, let's start from definition. The endocrine system, it is a group of glands or organs that regulate physiological functions by releasing hormones into the bloodstream. Hormones are chemicals that carry information to different parts of the body. Specific hormones influence certain organs or part of the body, such as liver or pancreas. The endocrine system regulates development and growth, for example, puberty, metabolism, sexual and reproductive processes. It includes the reproductive glands, adrenal glands, thyroid glands, hypothalamus, pancreas, and pituitary glands. Although distinct from the nervous system, the endocrine system interacts with the nervous system through the hypothalamus, which regulates the pituitary gland function. The word endocrine derives from the Greek words endo, meaning within, and krinis, meaning secret. Spectrum of endocrine diseases and metabolic disorders. First of all, it can be adrenal disorders. Here, the most often we include adrenal insufficiency, adrenal hormone excess. It is congenital adrenal hyperplasia, adrenocortical carcinoma. It is glucose homeostasis disorders like diabetes mellitus and hypoglycemia. And thyroid disorders, it is goiter, hyperthyroidism, hypothyroidism, thyroiditis, thyroid cancer, thyroid hormone resistance. All these disorders you will learn on cycle of endocrinology on 4th course. And now we will stop on main points about diagnosis of such disorders. Additionally, we include two endocrine diseases, calcium homeostasis disorders and metabolic bone diseases, like hyperparathyroidism, hypoparathyroidism, pseudohypoparathyroidism, osteoporosis, osteitis deformans. Moreover, it can be rickets and osteomalacia, and it can be pituitary gland disorders like posterior pituitary. Here we include diabetes insipidus, and anterior pituity, it is a range of disorders like hypopituitarism, pituitary tumors, hyperprolactinemia, acromegaly, gigantism, Cushing disease, growth failure, and dwarfism. Sex hormones disorders. Here it can be disorders of sex development, hypogonadism, disorders of puberty, menstrual function disorders. Tumors of the endocrine glands not mentioned elsewhere, multiple endocrine neoplasia and carcinoid syndrome. And let's start discussion of thyroid gland disorders. And first of all, let's remind the position, anatomical position of thyroid gland. Here you see picture this position of this gland and what tissue, what organs, muscles, bones surround the thyroid gland. Primary functions of thyroid gland. The primary function of thyroid is production of hormones T3, T4 and calcitonin. Up to 80% of the T4 is converted to T3 by organs such as liver, kidney and spleen. T3 is several times more powerful than T4, which is largely a prohormone, perhaps 4 or even 10 times more active. I hope you remember all the things from the physiology, and let's remind it one more time. The production of T3, T4 is regulated by thyroid stimulating hormone or TSH released by anterior pituitary. The thyroid and thyrotropes form of negative feedback loop. TSH production is suppressed when the T4 levels are high. We name it one more time negative feedback loop. T3, T4 act on nearly every cell in the body to increase the basal metabolic rate, affect protein synthesis, help regulate long bone growth and neural maturation, and increase the body's sensitivity to catecholamines by permissiveness. T3, T4 are essential to proper development and differentiation of all cells of the human body. T3, T4 also regulate protein, fat, and carbohydrate metabolism, affecting how human cells use energetic compounds. They also stimulate vitamin metabolism. Numerous physiological and pathological stimuli influence T3, T4 synthesis. T3, T4 leads to heat generation in humans. And chemical formation of thyroxine in 3-iodothyronine. You see that on the first part of this picture, a molecule of proteins that we name tyrosine. Yes, and it goes to the process that we name iodination. It includes some molecules of iodine. And if it includes 4 molecules, additional molecules of iodine, and it includes 2 tyrosine molecules, it formates T4 or thyroxine. If it is 2 molecules of tyrosine take 3 molecules of iodine, it will be 3-iodothyronine or T3. And several more moments. Thyroid secretes about 80 milligrams of T4 but only 5 milligrams of T3 per day. T3, we told it has a much greater biological activity, about 10 times, than T4. An additional 25 milligrams a day of T3 is produced by peripheral mode of deiodinization of T4. And effects of thyroid hormones T3 and T4 for different systems. For cardiovascular system, they increase heart rate, increase force of cardiac contraction, and increase cardiac output. Moreover, it upregulate catecholamine receptors. For respiratory system, it increase resting respiratory rate. They increase minute ventilation, increase ventilatory response to hypercapnia and hypoxia. In the renal system, T3 and T4 increased blood flow, increased glomerular filtration rate, For intermediary metabolism, they increase glucose absorption from the GI, increase carbohydrate, lipid, and protein turnover, downregulate insulin receptors, and increase substrate availability. Oxygen carrying capacity, they increase red blood cells mass, they increase oxygen dissociation from hemoglobin. Their influence on growth and tissue development. T3 and T4 increase growth and maturation of bone and tooth, increase growth and maturation of epidermis, hair follicles, and nails. They increase and force of skeletal muscle contraction. They inhibit synthesis and increases degradation of mucopolysaccharides in subcutaneous tissue. Their effect on nervous system, it is critical for normal central nervous system neuronal development. They enhances wakefulness, alertness, memory, and learning capacity. T3 and T4 required for normal emotional tone. They increase speed and amplitude of peripheral nerve reflexes. Their influence on the reproductive system. They are required for normal follicular development, ovulation, maintenance of pregnancy in the female, and spermatogenesis in the male. Yes, thyroid gland. Yes, regulation of thyroid gland. It is controlled by the hypothalamus and pituitary. Through the feedback loop, I told you several words what is that. The pituitary releases TRH, or the thyrotropin releasing hormone, which stimulates the release of TSH, or thyroid stimulating hormone. Thyroid stimulated hormone, or TSH, stimulates in its own they stimulate a thyroid gland to produce the hormones T3, T4 to release them into the blood. Okay. Purpose of investigation of patient with thyroid gland disorders. It is general evaluation of health. It is diagnosis of disease or disorders of the thyroid gland and diagnosis of other systemic diseases that affect the thyroid gland function. You saw in previous slide how much systems are affected and are influenced by the thyroid function. That's why a lot of systems, nearly all systems and organs in our organism can suffer and can have some symptoms in thyroid gland disorders. And here you see a very specific symptom of thyroid disorder. We name it exophthalmia. You see how it's deformation of eyes in patient with thyrotoxicosis. History taking of patients with thyroid gland and disorders. During interviewing, we are gathering of information. We pay attention to patient's narrative, to biomedical perspective, psychosocial perspective, and context. Yes, and you see picture of goiter. That's what goiter means: enlargement, visible enlargement of thyroid gland, or non-visible in some cases. Here you see how a large thyroid gland that it enlarge anterior surface of neck and it become visible. On this picture you see enlargement and goiter too in much more younger patient. Yes, that we can find during inspection and palpation. A normal thyroid is estimated to be 10 grams with an upper limit of 20 grams. An enlarged thyroid is referred to as a goiter. There is no direct correlation between size and function. A person with a goiter can be euthyroid, hypothyroid, and hyperthyroid. One more time, please pay attention to this sentence. It is no correlation, no direct correlation between size of gland and function of gland. size can be enlarged, normal, or decreased, and in all these cases function can be normal, can be increased, or can be decreased. In small gland it can be hyperfunction, in big gland it can be hyperfunction, and all other situations. No correlation between these facts. World Health Organization classification of goiter or thyroid enlargement. Grade 0, it is no palpable or no visible thyroid gland. Grade 1, it when the thyroid is palpable but not visible, when the neck is in the normal position. Thyroid nodules in a thyroid which is otherwise not enlarged fall into this category. And grade 2, it when thyroid is clearly visible when the neck is in normal position and is consistent with an enlarged thyroid when the neck is palpated. Examination laboratory. Yes, here we testing blood. In the blood we must check the thyroid stimulating hormone TSH. It is evaluate overall thyroid function. It is the most useful, the most sensitive and very usable for screening of thyroid function test. Additionally to it, we can check levels of T3 and T4. Total thyroxine, or T4, evaluates the total amount of T4 produced by thyroid gland. Free T4 evaluates the amount of T4 available to the cells and tissues. Free 3-iodthyronine, or T3, measures the amount of T3, the active form of the hormone available to the cells and tissues. Yes, and one more time, thyroid panel, you remember, negative biological feedback. Yes, in most cases when, for example, T4 is high, we name it hyperthyroidism or hyperfunction or thyrotoxicosis, TSH will have opposite result, it usually low. When it is hypothyroidism or decreased function of thyroid gland, it will be decreased T4 but opposite high TSH. But if we have secondary hypothyroidism that cause not in the thyroid gland and cause irregulation in pituitary or in hypothalamus, we name it secondary hypothyroidism. Both of these hormones, TSH and T4, can be normal, and it is the most specific differential sign how to differentiate primary, secondary, hyper and hypothyroidism. And of course, in healthy person, both of them will be normal. And possible results of interpretation of thyroid panel. Yes, when TSH is high, T4 and T3 normal, we name it mild or subclinical hypothyroidism. I told you that TSH is the most sensitive and it responds on some problem, organic problem is the first. And during some time, high TSH can compensate deficiency of T3 and T4, and in blood their levels will be normal. But it's starting of hypothyroidism. That's why we name it mild or subclinical hypothyroidism. The opposite situation, when it is low TSH but normal T3, T4, we name it mild subclinical hyperthyroidism or thyrotoxicosis. Situation when it is high TSH and low T4 and low or normal T3, we name clinical hypothyroidism. The opposite, when it is low TSH, high T4, high or normal T3, it will be hyperthyroidism or thyrotoxicity. When always everything is low, it is non-thyroidal illness, a rare pituitary secondary hypothyroidism. And when it's possible situation when we see normal TSH but high levels of T3 and T4, it will be thyroid hormone resistance. We moreover in not just hormonal panel we can check thyroid antibodies, because on endocrinology you will learn that most disorders of thyroid gland will have autoimmune nature. That's why in most of these patients for differential diagnosis we must check antibodies level. What antibodies we usually check? It is thyroid peroxidase antibody, it is thyroglobulin antibodies, and thyroid stimulating hormone receptors antibodies. And here in this table you can fix it and see what of these three main antibodies, thyroid peroxidase, thyroglobulin, and thyroid stimulating hormone receptors antibodies, in which disorders we can find an increased level of these antibodies. Visualization of thyroid gland, the most usable test, it is ultrasound. It is parenchymatous organ, it is very good visible on ultrasound. That's why thyroid ultrasound or sonography give us a lot of information. Like an example, on first picture you see a normal position, a normal structure on thyroid gland. By the rows you see right and left lobe, a black round. It is not a cyst like you can see, it is the cavity of artery, and between right and left lobe you see a black space where we can visualize trachea. And second picture, it is partial thyroid ectomy, when it is removed surgically right lobe or thyroid gland. Doppler sonography, you know this method, we use it for checking blood flow. Is it increased, like for example in some malignancies when it is local increasement, diffuse increasement of increased vascularization, diffuse specific for autoimmune disorders of thyroid gland, and it can be decreased vascularization if it typical for autoimmune too, and for other structural disorders of thyroid gland. It can be scintigraphy or radionuclide scanning. Yes, when we inject patient radioisotopes that can be accumulated by thyroid gland. And on first picture you see a normal level of accumulation, and second picture it is autoimmune disorders with thyrotoxicosis. The most often of them we name Graves' disease, and you see such an intensive accumulation of radioisotopes can be in these disorders. Additionally, when we are not sure about nature of thyroid disorders, we can do thyroid biopsy. Here on this picture you see that under the control of ultrasound, when doctor see the picture of thyroid gland and its structure, we inject end catheter to take in some small piece of tissue or some structure in thyroid gland for morphological visualization. Additionally, we can use CT scanning, and here is pictures of CT scans. Most thyroid disorders affect cardiovascular system, especially that affect thyroid function, both as hypothyroidism as hyperthyroidism affect heart and vessels function, and especially heart electricity. That's why a lot of tachycardias, arrhythmias, palpitations can be caused by thyroid problems. That's why for diagnosis diagnosing these problems, all patients with thyroid gland disorders should undergo ECG. And here you see two strips. Upper strips, it is a patient with atrial fibrillation, that is typical complication of thyroid disorders. And second picture, it is for comparison the normal ECG. And several words about different pathologies. First, it is hypothyroidism. Etiology. It can be primary. It usually caused by Hashimoto thyroiditis with or without goiter. It is the most often pathology of thyroid gland at all. It is radioactive iodine therapy for Graves' disease, like a iatrogenic complication of the therapy. It can be subtotal thyroidectomy for Graves' disease or nodular goiter. It can be excessive iodine intake. It can be subacute thyroiditis, and more rare causes like iodine deficiency, goitrogen such as lithium, antithyroid drug therapy, inborn errors in thyroid hormone synthesis. Secondary hypothyroidism caused by hypopituitarism, when problem not in thyroid gland and problem with regulation. It can be tertiary or hypothalamic dysfunction and peripheral resistance to the action of thyroid hormone. Age aspects of hypothyroidism. Early onset in childhood, it is delayed or incomplete physical and mental development. It may development of cretinism. More later onset in young age, it is impaired physical growth. And hypothyroidism in adults, in most severe cases we name it myxedema. It is gradual changes occur: tiredness, lethargy, decreased metabolic rate, slowing of mental function and motor activity, cold intolerance, weight gain, goiter, hair loss, dry skin, eventually may result in coma. Okay, what is goiter belt? Yes, it is Midwest and it connected with iodine deficiency. During iodine deficiency, it is thyroid hormone production decreases. Yes, more early it was a very important problem because a lot of countries that are not, and a lot of regions that are not near the seaside, and especially the mountain regions, they are was very typical for iodine deficiency, and this iodine deficiency in a lot of people lead to hypothyroidism. But last years this problem was resolved in a very simple way. All these regions and most of these countries use iodine salt in everyday usage. That's why problem of iodine deficiency for today and very largely decreased. In this case, it possible, and nowadays cases of iodine deficiency, TSH can release increased by less negative feedback. TSH acts on thyroid, increasing blood flow and stimulating follicular cells and increasing colloid production. But the only result is that the follicles accumulate more and more unusable colloid. If goiter is due to decreased iodine, then goiter gland enlarged. We name it endemic or colloidal goiter. Cells eventually die from overactivity and the gland atrophies. Thyroid clinical symptoms of hypothyroidism. Cardiovascular system include bradycardia, low voltage ECG, pericardial effusion, cardiomegaly, and hyperlipidemia. Moreover, it can be constipations, ascites, weight gain, cold intolerance, raw, dry, yellowish skin, puffy face and hands, hoarse, husky voice, and respiratory failure. In female, it can be menorrhagia, infertility, hyperprolactinemia. Renal disorders include impaired ability to excrete a water load. It can be anemias by impaired hemoglobin synthesis, ferrum deficiency due to menorrhagia, and reduced intestinal absorption, folate deficiency due to impaired intestinal absorption, and pernicious anemia. Neuromuscular symptoms. It can be muscle cramps, myotonia, slow reflexes, carpal tunnel syndrome. Symptoms from central nervous system include fatigue, lethargy, depression, inability to concentrate. Diagnosis: we should put according to levels of T4 and TSH for primary hypothyroidism. For serum T3 levels can be variable. It will be positive test for thyroid antibodies, for thyroglobulin or thyroperoxidase, and enlarged thyroid gland, like in Hashimoto thyroiditis. Levels of relation between T4 and TSH inappropriately normal. Typical for mixed edema. Absence of TSH response and TRH in pituitary deficiency. If TSH is high and normal T4 and T3, we're told that it is subclinical hypothyroidism. And the most severe cases or case of hypothyroidism, it is a mixed edema coma. It is medical emergency and stage of untreated hypothyroidism with progressive weakness, stupor, hypothermia, hypoventilation, hypoglycemia, hyponatremia, shock, and death. The patient or a family member may recall previous thyroid disease, radioiodine therapy, or thyroidectomy. Gradual onset of lethargy progressing to stupor or coma. It can be marked hypothermia. The temperature of the body can be less than 24 grades by Celsius. Heart failure, pneumonia, excessive fluid accumulation are typical for these patients and need for narcotics. On ECG, it usually bradycardia and low voltage of all waves. It will be very decreased level of T4. TSH can be normal, high cholesterol or serum sodium. And the opposite situation, we name it hyperthyroidism. Etiology of it: the second most prevalent endocrine disorders after hypothyroidism. Affects women 8 times more frequent than men. It may appear after the emotional shock, stress, or an infection. The most often disease we name Graves' disease. It is excessive output of thyroid hormone. Other common causes of hyperthyroidism include thyroiditis and excessive ingestion of thyroid hormone, toxic adenoma, Plummer's disease, and toxic multinodular goiter. Clinical symptoms of hyperthyroidism: emotional disturbances like nervousness, irritability. It can be exophthalmos. I showed you pictures with this symptom. It will be goiter or diffuse enlargement of the thyroid and brood. It can be thyroid dermopathy with pretibial myxedema. It can be heat intolerance, Cardiovascular symptoms include palpitation, atrial fibrillation, chronic heart failure, dyspnea, and angina. Gastrointestinal symptoms, it is weight, appetite, diarrhea, reproductive amenorrhea, oligomenorrhea, infertility, and gynecomastia. Bone symptoms with osteoporosis, thyroid acropathy, neuromuscular with nervousness, tremor, emotional lability, proximal myopathy, myasthenia gravis, hyperreflexia, clonus, periodic hypokalemic paralysis. Skin changes with pruritus, onycholysis, vitiligo, hair thinning, palmar erythema, spider nevi. Diagnosis of hyperthyroidism. TSH usually decreased in this case with high levels of T4 and or T3. If eye signs are present, the diagnosis of Graves' disease can be made without further tests. If eye signs are absent and the patient is hyperthyroid with or without goiter, a radioiodine uptake test should be done. Radioiodine uptake and scan are needed for confirming diagnosis of hyperthyroidism. TSH is specific. TSH receptors antibodies is specific for Graves' disease. May be useful the apathetic hyperthyroid patients or who present with unilateral exophthalmos without obvious signs or laboratory manifestations of Graves' disease. And the emergency in hypothyroidism, the most severe cases we named thyroid storm or thyroid crisis. It occurs in severely hyperthyroid patients caused by precipitating events such as infection, surgical stress, stopping antithyroid medication in Graves' disease. Clinical clues. In thyroid storm, it is fever with hyperthermia, marked anxiety or agitation that can lead to coma. It can be anorexia, tachycardia and tachyarrhythmias. It can be pulmonary edema and cardiac failure, hypotension that can lead to shock and confusion. And now we start second part of our lecture. It is a lecture that connected with endocrine pancreas and disturbances of its function. And here you see picture with reminding of anatomy and physiology of pancreas in general and endocrine pancreas specifically. Sorry, it is several old slides. They are about another department, another website, which I worked previously. Okay, endocrine pancreas. The primary functions are production of pancreatic hormones by three cell types. It is glucagon by alpha cells, insulin by beta cells, somatostatin by delta cells. Hormones travel through the bloodstream to target tissues. At the target cells, hormones bind specific receptors and cause cell changes that control metabolism. Here you see the scheme that show us that insulin and glucagon, it is the two main hormones of endocrine pancreas. They keep balance of glucose metabolism in our body. Where insulin has effects with glucose oxidation, glycogen synthesis, fat synthesis, and protein synthesis. And glucagon has mostly opposite effect with increased glycogenolysis, increased gluconeogenesis, and ketogenesis. And the general homeostasis, glucose homeostasis, is connected with balance of these hormones. Structure and roles of insulin. Insulin, it is polypeptide hormone composed of two chains, A and B. Both chains are derived from proinsulin or prohormone. Chains are joined by disulfide bonds. Acts on tissues to increase uptake of glucose and amino acids, increases glycogen production or glucose storage in the liver and muscle, stimulates lipid synthesis from free fatty acids and triglycerides in adipose tissue. Also stimulates potassium uptake by cells, role in potassium homeostasis. Chemically, high levels of glucose and amino acids in the blood. Hormonally, mechanisms. Beta cells are sensitive to several hormones that may inhibit or cause insulin secretion. And neurally mechanisms, it is stimulation of parasympathetic nervous system causes insulin to be secreted. Insulin secretion is decreased by decreased glucose and increased insulin concentration in blood and sympathetic stimulation. Insulin transported through the blood to target tissues where it binds to target cell-specific receptors and acts as a biochemical signal to the inside of the cell. Cell metabolism is stimulated. To check function of endocrine pancreas, we have to check level of glucose. How we check a glucose level? First test we named blood fasting glucose level. A normal range, it is a narrow range about 3.9 to 5.5 millimoles per liter, as measured by fasting blood glucose test. When we told hyperglycemia, we mean high levels of glycemia. During short term, it can be physiological or pathological. When hyperglycemia is persistent, it can be impaired function due to prediabetes and high due to diabetes mellitus. And opposite situation we name hypoglycemia, when we find a low levels of fasting glucose. Purpose of investigation of endocrine pancreas disorder patient. Yes, all these purposes are the same with other organs is system. It is general evaluation of health. It is diagnosis of disease or disorders of endocrine pancreas and diagnosis of other systemic diseases affect endocrine pancreas. History taken during interviewing. It is gathering of information, patient's narrative, biomedical perspective, psychosocial perspective, and context. The same with other organs. Here, it is important clinical monitoring, yes, because the primarily diabetes, I will say to you, that have just several symptoms. Hyperglycemia has just several features and symptoms, and most big range of different disorders, different problems, diseases, symptoms that we see in diabetic patient. They are connected with diabetes complications. That's why all tests that we usually do, we do it to diagnostic complications. It is affecting of blood pressure. We should manage blood pressure. We can do monitoring of hypertension and thus risk of heart disease. Obligatory, we have to do eye examination with management, monitor onset and progression of eye disease. We have to do foot examination with monitoring onset and progression of nerve disease and peripheral artery disease. Both of these problems affect foot. The indications for testing. In what cases we have to do some testing to confirm or not confirm diabetes mellitus. First recommendation according to American Diabetes Association, it is obesity. When BMI is more than 25 kilograms per meter. It is considered testing to detect pre-diabetes mellitus and type 2 diabetes mellitus in asymptomatic people. Family history of diabetes mellitus in first or second degree relative, it is indication for examination of this patient. Signs of insulin resistance or conditions associated with insulin resistance like acanthosis nigricans, hypertension, dyslipidemia, low birth weight. The maternal history of diabetes mellitus or gestational diabetes mellitus during gestation. What a panel of tests we usually do for patients with suspected diabetes mellitus. It is complete blood count or CBC. It is level of glucose in serum. Yes, the symbol of them it is fasting glucose. More, we can do the test that named oral glucose tolerance test. It is random blood glucose, can be checked especially in some emergencies or in primary visit of patient to the hospital. It can be islet cell antibody test. It is important for type 1 diabetes mellitus. Additionally, we use hemoglobin A1C or glycolysated or glycated hemoglobin, and more, it is diabetic urea analysis. The current World Health Organization diagnostic criteria for diabetes should be maintained. That fasting plasma glucose more than 7 millimoles per liter or in milligrams per deciliter 826, or 2 hours plasma glucose more than 11.1 millimoles per liter or 200 milligrams per deciliter. What is glucose oral tolerance test? In this test, we do fasting glucose in patient in the morning before breakfast, before eating. After it, we give patient solution of 40 grams of glucose in water. Patient take it and we recheck the series of glucose levels. And for a person without diabetes, the level after 2 hours after taking glucose, it don't have to be more than 11.1. Glycated hemoglobin more than 6.5, it is a sign of diabetes mellitus. And its level from 5.7 to 6.4, it is a sign of pre-diabetes, or at least it can be a risk of diabetes. Glycated hemoglobin reflects average plasma glucose over the previous 2-3 months. Why? Because it is a term of life of erythrocytes. In a single measure, it can be performed at any time of day and does not require any special preparation such as fasting. Okay, interpretation of laboratory examination of function of endocrine pancreas. Yes, here you see different markers. It is fasting glucose, oral glucose tolerance test, and glycated hemoglobin, which range you see first row typical for diabetes. When it is when it is a little bit less, a middle range, it says you about pre-diabetes or increased risk of diabetes. And typical changes of this test for gestational diabetes. All it you see in this table. Okay, diabetic urea analysis. Glucose urea can be detected when level of blood glucose exceeds more than 11 millimoles per liter. In healthy person, you usually don't find glucose in urea analysis. Urine tests can't be used too long to confirm the diagnosis of diabetes mellitus. They are ordered more often there is suspicion of type 1 diabetes. Laboratories can test urine for ketone bodies. The body produces ketone bodies, then fat tissue is used for energy instead of blood sugar. If ketone bodies are present in the urine, this could indicate the high level of glucose in blood with insufficient level of insulin production. And for individual checking for controlling by patients self-controlling glycemia levels, they use devices that we name glucose meters that check level of glycemia in capillary blood by technique that you see on this picture. Additionally, it can be used continuous glucose monitors. They look like this. It is a small device that fixed usually on abdomen, catheter fixed on abdominal surface that check every 5 minutes and providing alarms when glucose levels are too high or too low and are rapidly rising or falling. High-level persistent hyperglycemia, yes, or diabetes mellitus. What about type 1 diabetes mellitus? You remember that it can be 3 main types of diabetes. It is type 1, type 2, and gestational diabetes. In clinical practice, it is much more different types of diabetes, but all of them you will learn on endocrine course. What about type 1 diabetes? Several words. Diabetes mellitus type 1 results from the body's failure to produce enough insulin. Main risk factor is viruses and toxins that can affect genetically determined antigens of HLA system and cause autoimmune destruction of beta cells in the islets of Langerhans. Diabetes type 2. It begins with insulin resistance, a condition in which cells fail to respond to insulin properly. In this case, it is enough number of insulin, the opposite from the type 1, but it is abnormal function that cells are not able to respond for this insulin. As the disease progresses, a lack of insulin may also develop. This form was previously referred to as non-insulin-dependent diabetes mellitus or adult-onset diabetes. The primary cause is excessive body weight and lack of exercise. And type 3 or gestational diabetes, it is the third main form and occurs when pregnant women without previous history of diabetes develop a high blood glucose level. If this female previously have diagnosed diabetes, hyperglycemia during pregnancy is not mean gestational diabetes. It refers to her main disorder, her diabetes mellitus. Type 1 or type 2. Classic and non-classic clinical symptoms of hyperglycemia or diabetes mellitus. It's what I told you. It can be just several main symptoms of hyperglycemia. All of them, three main of them, start from poly. It is polyphagia or increased hunger, polyuria or frequent urination, and polydipsia or increased thirst. Other or non-classic symptoms include blurred vision, fatigue, weight loss, poor wound healing, cuts, scarpet, etc. It can be dry mouth, dry or itchy skin. It can be impotence in male. It can be recurrent infections such as vaginal yeast infections, groin rash, or external ear infections like a swimmer ear. Early clinical symptoms. In early stages of disorders, it can be frequent urination, increased thirst, blurred vision, fatigue, headache. Molate. They are connected mostly with ketoacidosis, that is more typical for type 1. It can be fruity smelling breath, nausea, vomiting, shortness of breath, dry mouth, weakness, confusion, coma, or abdominal pain. And you see here schemes of early and later clinical symptoms by some funny pictures. It is weight loss, extreme tiredness, increased hunger, excessive thirst, frequent urination, tingling and numbness, blurred vision, unhealed wound, and urine are touching ants. And one more time, schematically, symptoms of diabetes by organs and systems. Complications. Main acute complications include diabetic comas, and before it comas, it metabolic disorders, and most often of them we name diabetic ketoacidosis. It is a potentially life-threatening complication, happens in patients with diabetes mellitus type 1, but can occur in those with diabetes mellitus type 2, much more rare but possible. These symptoms usually evolve over a period about 24 hours. Predominant symptoms are nausea and vomiting, pronounced thirst, excessive urine production, and abdominal pain. Breathing becomes labored and of a deep, gasping character, like Kussmaul respiration. In severe cases, there may be confusion, lethargy, stupor, coma. On physical examination, there is evidence of dehydration like tachycardia, low blood pressure, ketotic odor, and death. Blood analysis will reveal significant decreased pH, like less than 7.3 millimoles per liter. Urine analysis will reveal significant levels of ketone bodies, often before other overt symptoms. An acute complication of another coma or another state that we name non-ketotic hyperosmolar state, sharing many symptoms with diabetic ketoacidosis, but an entirely different origin. Water osmotically drawn out of the cells into the blood. The kidneys in this case eventually begin to dump glucose into the urine. Serum pH more than 7.3, bicarbonate more than 15, small ketone urea, and absent to low ketone amia, less than 3 millimoles per liter. Increased risk of blood clot formation. In this case, if fluid is not replaced, the osmotic effect of high glucose level combined with loss of water will eventually lead to dehydration. Some alterations in conspicuous lethargy may ultimately progress to a coma. Coma. In patients with diabetes mellitus, in severe cases, In a short period, this hyperosmolality and hyperketonemia can lead to coma. It's life-threatening diabetes mellitus complication that causes unconsciousness. We can divide it on 3 different types. With severe low blood sugar in diabetes mellitus person, with diabetic ketoacidosis advanced enough to result in unconsciousness from a combination of severely increased blood sugar level, dehydration and shock, and exhaustion. And third type, it is hyperosmolar non-ketotic coma that is a result of hyperosmolar non-ketotic state, in which an extremely high blood sugar levels and dehydration alone are sufficient to cause unconsciousness. Diabetic coma was a diagnostic problem before a late 1870s when glucometers and rapid blood chemistry analyzers became universally available in hospitals. Hypoglycemia. It is a medical emergency that involves an abnormally diminished content of glucose in the blood. Symptoms of hypoglycemia usually do not occur until 2.8 to 3.0 millimoles per liter. Adrenergic manifestations is typical for hypoglycemia. It is shakiness, anxiety, nervousness, palpitations, tachycardia, sweating, pallor, coldness, clammness, and mydriasis. Glucagon manifestation can include hunger, nausea, vomiting, abdominal discomfort, and headache. Neuroglycopenic manifestations, abnormal thickening, depression, crying, exaggerated consent, paresthesia, negativism, emotional lability, fatigue, weakness, apathy, lethargy, daydreaming, confusion, amnesia, blurred vision, automatic behavior, difficulty speaking, incoordination, motor deficit, paresthesia, headache, stupor, coma, etc. Chronic complications of diabetes mellitus. If ketoacidotic, hyperosmolar states and comas and hypoglycemic coma was the acute complication, chronic complication can include a big range of disorders too. All of them we can divide it on vascular and neurological, and vascular divided on microvascular and macrovascular. Microvascular includes diabetic cardiomyopathy, diabetic neuropathy, diabetic nephropathy, diabetic retinopathy, and diabetic encephalopathy. Macrovascular complications include coronary artery disease, diabetic myonecrosis, peripheral vascular disease, and possible stroke. Other complications include gastrointestinal disorders like gastroparesis and diarrheas, that is a result of neuropathy too, genitourinary like uropathy and sexual dysfunction, dermatological disorders, infections, cataracts, glaucoma, and periodontal disease. And here you see the most danger and unfortunately most often results of chronic complications of diabetes mellitus. Yes, it is a blindness like a diabetic disorders of eye. It can be kidney failure, it can be heart attack and amputation due to diabetic foot. The blindness ED result in most cases of diabetic retinopathy. Diabetic retinopathy results in scarred hemorrhages, yellow exudate, and neovascularization. All these symptoms you can see on the picture. This patient has neovascular vessels proliferating from the optic disc, requiring urgent panretinal laser photocoagulation. And a little bit more about hypoglycemia. It is a low blood sugar, common with diabetes mellitus. In most cases are mild but not considered medical emergencies. Effects can range from the feeling of unease, sweating, trembling, and increased appetite in mild cases to more serious issues, such as confusion, aggressiveness, seizures, unconsciousness, and rarely permanent brain damage and death in severe cases. And one more time by scheme, the clinical symptoms of hypoglycemia. Please pay attention for them one more time because it is a very quick and very dangerous disorder in diabetic patient, and normal help, normal treatment and management of this state can save a life of diabetic patient. That's why symptoms include shaking, sweating, anxious, dizziness, hunger, fast heartbeat, impaired vision, weakness and fatigue, headache, and irritable. And for today, that's all. As usual, if you have questions, if you have comments, you can write it in our Facebook page, and in our comments under this video, I ask to write a name and groups of students that listen my lecture. And goodbye, see you next lecture.